Okay, let's start. Um, so the last video got cut. Well, it didn't get cut off. The audio wasn't the best. When I talked about pneumocystitis, Jaravici, and sporothorax. So I want to go over that again. Um, the verse of the day: Cast your cares on the Lord, and He will sustain you. He will never let the righteous be shaken. Psalms 55:22. Okay. Um, Here, pneumocystitis jirovecii, it causes pneumocystitis pneumonia or PCP pneumonia, a diffuse interstitial pneumonia, like seen in A right here. You see um, like a cloudiness in both lungs. Okay. Now, it is a yeast-like fungus, originally classified as a protozoan, but it is a yeast-like fungus. Pneumocystitis jirovecii, most infections are asymptomatic. Immunosuppression, like in AIDS patients, predisposes to the disease. There is diffuse bilateral ground glass opacities on chest imaging with pneumatoceles. So you see this on in figure B. Um, it looks like a ground glass appearance, like broken glass all over your lungs. That's what pneumocystitis jirovecii looks like on um, on chest imaging. Okay. Um, this is diagnosed by pneumocystitis jirovecii is diagnosed by bronchoalveolar lavage or lung biopsy. It is a disc-shaped yeast seen on methenamine silver stain of the lung tissue. You see this in option C. So the pneumocystitis jirovecii looks like discs, and you see it on silver stain. Okay, don't forget silver stain, or with fluorescent antibody. The treatment and prophylaxis. Okay, so we're gonna do the treatment first. So TMP-SMX, and then pentamidine and dapsone, and dapsone paired with TMP-SMX or atovaquone is used for treatment. Now, for just talking prophylaxis, you give dapsone by itself. Okay. Um, so you start prophylaxis when the CD4 count drops to less than 200 cells in HIV patients. Okay, so you start prophylaxis when CD4 count drops below 200 in HIV patients, which is dapsone. Dapsone is prophylaxis. Now, pneumocystitis jirovecii is an AIDS-defining illness. It's transmitted by respiratory droplets. So when somebody caught with this uh, this fungus coughs, the spores of that is inhaled by somebody else, and let's say that patient is a HIV patient and their CD4 count, they're not combined with their antiretrovirals, and that their CD4 count drops to below 200 because they have inhaled this pneumocystitis jirovecii, their CD4 count will drop to below 200, and that's when you start prophylaxis with dapsone. Now, if they already have a CD4 count of 150, and they have this ground glass appearance on the chest imaging, um, they already have the disease, the PCP pneumonia. It is an AIDS-defining illness. Okay. So the patient is allergic. If the patient is allergic to TMP-SMX, you give pentamidine. So if the patient is allergic to sulfa drugs, you give pentamidine. And the susceptibility to PCP becomes an issue when CD4 count drops below 200. And then in figure A, the infection spreads in ascending pattern along The path of draining lymphatics mm, spreads in ascending pattern. Ascending, that means it goes from um, the bottom to the top. Infection spreads in ascending pattern along the path of draining lymphatics. Okay. Um, Figure B, diffuse interstitial pneumonia that looks like ground glass or broken glass. Figure C, bronchoalveolar lavage stained with methamine silver to identify PCP that will look like a disc-shaped yeast. Now, I'm going to go into sporothics quickly. Sporothics Schenki causes sporotrichosis. It's a dimorphic fungus, which means that it can convert to either a yeast or a mold. Um, Sporothics exists as a cigar-shaped yeast at 37 degrees Celsius, which is 98.6 Fahrenheit, in the human body, and as hyphae with spores in the soil. Um, Candida. Candida is just what it looks like. It looks like a flower in the soil. Okay. This sporothrix lives on vegetation. When spores are traumatically introduced into the skin, typically by a thorn, it causes local pustule or ulcer with nodules draining the lymphatics in an ascending lymph, lymphangitis. Dysentery disease possible in immunocompromised host. Treatment is with itraconazole or potassium iodide only for cutaneous or lymphocutaneous um, cases. So for skin issues, you give itraconazole or potassium iodide. Um, Rose gardeners get this because Sportex is found on rose bushes. I would know because I accidentally jumped into one, right into one that was like 5 feet tall, or yeah, it was about 5 feet. It was my height. I thought I could jump over it, but I fell right into it. Whereas my brother and my sister escaped while we were sneaking out of the house to buy McDonald's. So we were kids, we were small kids, and yeah, I fell into a rose bush. I had these pustules over like 2 to 3 spots. I remember it kept draining, and it was horrible. I literally thought I was dying. Um, yeah, my dad did. They didn't know what it was. We couldn't tell them. We snuck out of the house to buy McDonald's at 2 a.m. So 1 or 2 a.m. But yeah, I remember that's very specifically. My brother had to pull me out. Tris, my sister, she also had to pull me out. So it was it wasn't fun. I will never forget this disease. I was trying to diagnose myself. I literally thought I was like, "This is MRSA." I don't know where I would get MRSA from, because I only knew about MRSA when I was little, because my mom was a nurse. But now I know it's Sporothrix. Sporothrix. All right. Next, we're gonna go on to protozoa. Yeah, protozoa. These are gastrointestinal infections. Giardia. Okay. Giardia, it presents with bloating, flatulence, foul-smelling, fatty diarrhea, often seen in campers and hikers. Think fat-rich Ghirardelli chocolates or fatty stools of Giardia. Yeah. Okay. Ghirardelli, something. I hate this chocolate. I hate this chocolate so badly. So I will absolutely remember GRDSs. So I used to be obsessed with this chocolate, and then me, my brother, and my sister ate this chocolate right before we got shockingly ill. And this is when we were kids. It was like we were thrown up. We could not make it up the stairs. I don't know. It was like severe food poisoning. I don't know what it was, but it just so happened we ate Ghirardelli right before we got sick, and to this day we can't eat Ghirardelli chocolate. So it had nothing to do with GRDSs. It's just I just remember I associate that with sickness. So GRDSs, you see bloating, flatulence, foul smelling, and fatty diarrhea, often seen in campers and hikers because they drink the water in the mountains, and this water has cysts in the water, and they consume that, and then that's why they get this disease, GRDSs. And diagnosis: you have multinucleated tropocytes or cysts in the stool and you can also know its giardiasis by antigen detection. Okay, multinucleated trophocytes. Um, multinucleated trophocytes. Okay, this is multinucleated trophocytes is A. Figure A right here. So it has many nucleuses. I'm just gonna make this giardia. Okay, so multinucleated trophocytes, which is the a form of Giardia, or cysts. Cysts are larvae. You see the cysts in the stool, in the patient's stool, and so you see baby worms in the patient's stool. That's how you know it's Giardia. There's nothing that grosses me out more than worms. Oh gosh. Okay. So yeah, and you can also do this with antigen detection. Treatment is metronidazole. Okay. Entamoeba histolytica. This causes amoebiasis, which is bloody diarrhea, which is also known as dysentery. You get liver abscess and right upper quadrant pain. Histology of the colon biopsy shows flask-shaped ulcers. And you also get this from drinking cysts in the water. Serology, so diagnosis by serology, antigen testing, and or trophocytes with engulfed RBCs, which is in figure C. So right here, figure C, this entire thing, it's a trophocyte, it's a trophocyte of the Entamoeba histolytica. It eats the RBC. So ingested RBC by Entamoeba histolytica. So Entamoeba histolytica gets hungry while on its way to the liver to make abscesses and grab some RBC to eat. So this entire thing is a Entamoeba histolytica, and these red dots inside 1, 2, 3, 4, 5, 6, they are all RBCs that the Entamoeba histolytica decided to swallow. Okay, so this is a very classical picture of Entamoeba histolytica. It likes to eat your blood. All right, now. Okay. Or cysts, okay. Serology, antigen testing, and or trophocytes with engulfed RBCs in the cytoplasm, or cysts with up to 4 nuclei in the stool. Okay. This is also multi-nucleated. Okay. Entamoeba eats erythrocytes. Okay. Now, the treatment is metronidazole, paromycin, or idoquinol for asymptomatic cyst passers. Okay, so the main thing you have to know about amoebiasis, or okay, or main thing you have to know about Entamoeba histolytica is that it has an abscess has anchovy paste consistency. Okay. So it Entamoeba histolytica likes to cause liver abscesses. The right lobe of the liver is most commonly involved site of amoebic liver abscess. So the right lobe of the liver is the most commonly involved site of amoebic liver abscess, and this liver abscess has an anchovy paste consistency. Okay. Now, the other thing you have to know, the colon biopsy will show ulcerations in the colon that look like flasks. Okay, that look like flasks. Um, and this Entamoeba histolytica likes to eat the RBCs. Um, Trophocyte eats RBCs, and RBC is in the trophocyte cytoplasm. The treatment is metronidazole, paromycin, or idaquanol for asymptomatic cyst passers. Um, so paromycin is a luminal agent to destroy the cysts. Yeah, that's all you need to. Well, serology is to detect the serology is to detect antiamoeba antibodies. Diagnosis is by stool OMP for Entamoeba histolytica. Okay, next. Cryptosporidium. Sporidium. It's a causes severe diarrhea in AIDS patients, mild disease in immunocompetent hosts. So, severe diarrhea in AIDS patients, and it causes watery diarrhea in healthy patients. Um, you get this by drinking oocysts in the water. Okay, the oocysts are acid fast on the stain, and you can also diagnose by antigen detection. So these are Cryptosporidium right here. Oocysts on acid fast stain seen in Cryptosporidium. The cysts composed of 4 motile sporocytes and sporocytes attached to the intestinal wall and cause diarrhea and small intestine damage. And it can also cause colitis. So what did I say? This is acid fast. That's why the oocysts of the Cryptosporidium are acid fast, and that's why they are purple. Cysts composed of 4 motile sporocytes and cysts composed of 4 motile sporocytes and sporocytes attached to the intestinal wall and cause diarrhea and small intestine damage. And it can also cause colitis. All right. So, cysts in the water, how do they get there? It's transmitted by infectious cysts passed through stool. So, I guess areas where they lack sanitation, somebody poops, and then it gets into the water. Somebody with the Cryptosporidium poops, and then the oocysts get into the water. The eggs get into the water, and then somebody like the hikers, they come and drink the water, or anyone pretty much comes and drinks the water, and then they get it, and then these sporocytes attach to your um, intestinal wall and cause diarrhea. Prevention is by filtering city water supplies, nitaxanide in immunocompetent hosts. Okay. Prevention is by filtering city water supplies, nitaxanide in immunocompetent hosts. Prevention is by filtering city water. Okay, so basically, where sanitation is poor. You can expect a Cryptosporidium because it's passed through poop. Filtering removes oocytes from infected water. So you can give nitaxanide or sparomycin for treatment. Okay, what is a trophocyte? Trophocyte is a growing stage in the life cycle of a parasite when they are absorbing nutrients from the host. So it's like the baby phase of the baby worm. Okay. Now we're gonna go on to protozoa CNS infections. Toxoplasma gondii. It's very important. You have to remember this. Okay. Okay. Toxoplasma gondii. In an immunocompetent person, it causes mononucleus-like symptoms, thereby negative heterophile antibody test. Where do you see positive heterophile antibody test? Heterophile antibodies are by agglutination of sheep. Okay. So, positive, I believe that's EBV. Let's just double check. Yeah, mononucleosis caused by EB, also known as human herpes virus. So in Epstein-Barr virus, you have positive heterophile test, and then in Toxoplasma gondii, you have a negative heterophile antibody test. Okay. Reactivation of AIDS. This will lead to brain abscesses, usually seen as multiple ring-enhancing lesions. Remember we talked about this? Ring-enhancing lesions right here. Those 1, 2, 3. It looks like a ring, getting bigger and bigger. Ring-enhancing lesions. Okay. Okay. So MRI, congenital toxoplasmosis. Yeah, this causes congenital toxoplasmosis. You see classic chorioretinitis, hydrocephalus, and intracranial calcifications in the baby. How is this passed? It is transmitted. Yeah, cysts in the meat, most common, or you can get it from oocysts in the cat feces, or the mom can pass it to the baby because this parasite it crosses the placenta. So pregnant women should avoid cats. Diagnosis by serology, where you can biopsy the tissue, and you see tachocytes. B. So figure B right here. That's known as a tachocyte. Seen in Toxoplasma gondii. Treatment is sulfadiazine and pyrethamine. Okay, so now we're going to go through what you have to really know about Toxoplasma gondii. It has a negative heterophile antibody test. Negative heterophile antibody test. It can be reactivated. Toxoplasma gondii can be reactivated in AIDS. So when your CD4 count drops below a certain amount, Toxoplasma gondii comes back up. It will come and take over. It's evil. Toxoplasma gondii. It's the brain, and then the way you see it is you see the MRI, you see ring enhancing lesions. And these are areas of brain abscesses, okay? Brain abscesses. abscess, brain abscess, brain abscess, seen as multiple ring enhancing lesions. Okay, so in a baby, you see chorioretinitis, hydrocephalus, and intracranial calcifications. Baby can get seizures and blindness and deafness. Okay, remember that. Intracranial calcifications. I remember like seeing a question about those intracranial calcifications. The UR likes to talk about those intracranial calcifications, chorioretinitis. That's just inflammation of the cornea. Chorioretinitis. Chorioretinitis. Okay. Chorioretinitis is a type of uveitis that causes inflammation of the eyes, retina, and choroid. Okay. So, choroid. It causes inflammation of the choroid and retina. That's what it looks like. Inflammation of the choroid and retina in the back of the eye, right here. So it's not the cornea, okay? It's the retina and the choroid. Okay? Alright. And hydrocephalus, which is enlarged head. Oops, this is hydrocephalus, right? This is due to so much CSF fluid in the ventricles, so the brain enlarges. The brain enlarges. See this? That is so sad. Spontaneous rupture or neglected huge hydrocephalus. Oh my gosh. How can you neglect? That's so sad. Oh my gosh. Guys, something else I know. I can't work with in the pediatrics floor. I can't do it, or the baby floor, or the NICU, or anything. I think I'm just someone who just wants to know about the diseases. I can't ever actually work in the floor with the pediatrics or babies. I love them so much. I can't even look at the pictures, and I'm just like, oh my gosh. Especially when they said neglected hydrocephalus. Oh my gosh, how could you neglect the hydrocephalus? Okay. Alright, so please don't forget, you see hydrocephalus, intracranial calcifications, and chorioretinitis in congenital toxoplasmosis, which is transmitted by Toxoplasma gondii. And you get this because you can eat the cysts in the meat. Cysts are larvae. So baby worms, you can eat the cysts in the meat, and then you can get it. And that is the most common way. You can get it from oocysts in the cat feces, so a cat feces, eggs in the cat poop. You can inhale it. Okay. Inhale it. Okay, so I don't know if the lady inhales it or ingests the eggs that are floating around. It just shows arrow marks. Oocysts are transmitted by ingestion. In order to contact a toxo, the person would have to make contact with contaminated feces in the litter box and then, with a washing hand, touch their mouth, or otherwise transmit the contaminated fecal matter to their digestive system. I see. So it's by ingestion. You don't inhale it, it's by ingestion. Okay. You can be, if you touch your mouth after changing the litter box, pregnant women, they can get it. So you don't inhale toxoplasmosis, you eat the eggs by accident. Oh, that's yeah. Oh, okay. Okay, oocysts in cat feces. Pregnant woman changes litter box, changes litter box, litter box, and what? And touches face, and it touches lips without washing hands, without washing hand. So she ingests oocytes, oocysts, oocysts. Okay. All right. So in Toxoplasma gondii, um, animals in nature have Toxoplasma gondii in them. So if someone eats meat from them, they can get the disease. So that's how cysts in the meat. That's how people normally get it. Cysts in the meat, larvae in the meat, baby worms in the meat. You eat them. It's not cooked properly. It's undercooked. You eat and you get it. Or a pregnant woman uh, changes the litter box and touches lips without washing her hands. So she ingests the oocytes of the Toxoplasma gondii. Now she has toxoplasmosis. Okay. So that's why pregnant women should avoid cats in general. Um, Diagnosis, serology. I wonder how many cats have carried Toxoplasma gondii. Oh my goodness. Oh hell no. Persian cats 60%? I have a friend who's obsessed with cats. I have to send it to her. This is whack. That's crazy. Oh heck no. Alright. That's not good. That's scary. Oh my goodness. Okay. Alright. Blood smear, blood stain, and gemsa stain. To see parasites in the RBC. So you do a blood stain and gemsa stain. Gemsa stain to see parasites in the RBCs. Oh my gosh, wrong page. Sorry, that's for plasmodium. Okay. Let's see. So toxoplasmosis is by serology. You biopsy the tissue and you see tachycyte, which we showed earlier. Okay, and the treatment is sulfadiazine and pyrethamine. Treatment is for active infection. So that is the treatment for active infection: sulfadiazine and pyrethamine. And the patient is seropositive. The patient is seropositive for IgG, for Toxoplasma gondii, and CD4 count of less than 100. You give TNP-SMX or prophylaxis. So if the patient is positive for IgG, for Toxoplasma gondii, and the CD4 count is less than 100, you give TNP-SMX for prophylaxis. So this is I'm talking about AIDS here. The patient has a positive immunoglobulin for Toxoplasma gondii and the CD4 count is less than 100. You give TNP-SMX. Okay, as a prophylaxis, and that's it for toxoplasmosis. Naegleria fowleri. It's a rapidly fatal meningoencephalitis. Transmission is by swimming in warm fresh water. Enters by the cribriform plate. Remember we talked about the cribriform plate where it was. It enters there. Diagnosis by amoebas in the CSF, which is here. Option C. Diagram C. See this right here? That is amoebas in the CSF seen in Naegleria fowleri. Now we're going to go up. Alright, the treatment is amphotericin B. Has been effective for a few survivors. So this thing, Naegleria fowleri, is extremely fatal. Stay home. Don't swim outside or unknown waters because there's not much you can do once it gets into your cribriform plate. Okay. So let's see. Naegleria fowleri affects patients involved in water. So it affects patients involved in water sports. Diagnosis by lumbar puncture. You get it from swimming in freshwater lakes. It is associated with nasal irrigation and systems and contact lens solution due to the water being stagnant. So, I mean, that's just another detail. It's associated with nasal irrigation systems and contact lens solution due to water being stagnant. But generally, people get it from swimming in freshwater lakes, and people who do, who are into water sports, and they swim in these lakes. This amoeba enters your body by the cribriform plate. So trophozoite enters the CNS by cribriform plate, then the brain, then it progresses to meningoencephalitis. You can give amphotericin B. And I'll just show you a picture of the meningoencephalitis. Okay. Let's see, meningio, and cephalitis, meningoencephalitis. So this is a meningoencephalitis. Meningoencephalitis is inflammation of both the meninges and the brain, okay? Trypanosoma brucei. This causes African sleeping sickness. You see enlarged lymph nodes, a recurring fever due to antigenic variation, somnolence, and coma. It's transmitted by the tsetse fly and is a painful bite. You see triple mastigotes in the blood smear, which is right here, D. Figure D right here. Mastigotes on the blood smear, seen in Trypanosoma brucei. Ceramine for blood-borne disease, or melarsoprostol for CNS penetration. Okay, so what you have to know about this is that Trypanosoma brucei is motile with a single flagella. It causes African sleeping sickness. You get enlarged lymph nodes, recurring fever due to antigenic variation. What is antigenic variation? It's a variable surface glycoprotein coats undergoing a constant antigenic variation. So basically, the glycoprotein of this organism keeps changing. Why is that? Because to keep evading the immune system, right? So it's harder to identify and catch when it keeps changing the outer layer of the organism. Okay, so it causes enlarged lymph nodes, recurring fever due to antigenic variation, somnolence, coma is carried by the tsetse fly. So after biting, the parasite moves from blood to the lymph nodes, so the patient gets cervical and axillary lymphadenopathy. So after biting the patient, the parasite moves from the blood to the lymph nodes, so it goes directly to the lymph node. They know where it hurts, so it goes to lymph nodes. That's why you see enlarged cervical and axillary lymphadenopathy. Tryptomastigot is in the blood smear. We just talked about it. This purple business right here. Okay. All right. So you get ceramine, or for blood-borne disease, melarsoprostol for CNS penetration. All right. So that's it for that, and we're gonna go on talk about. Before we go into the next thing, what are the torch infections? You have to know torch infections are toxoplasmosis, syphilis, varicella zoster, paravirus B19, rubella, CME, and herpes. We're going to get into that, but just know that for now. Now, we have to know that Plasmodium P. vivax, and ovale, Plasmodium falciparum, and Plasmodium malaria. So you have to know that there are 4 species of Plasmodium. P. vivax and ovale are very similar. So for our level now, we're going to classify as 1. And then second type of Plasmodium is Plasmodium falciparum. It's the third one. Plasmodium falciparum is the third one, and the fourth one is Plasmodium malaria. Okay, so next, malaria. The symptoms are fever, headache, anemia, splenomegaly. And in P. vivax and ovale, there's a 48-hour cycle. Includes fever on the first day and on the third day. Thus, fevers are actually 40 hours apart. Dormant from hypnocyte in the liver. And then falciparum is severe. There's irregular fever patterns. Parasitized RBCs occlude the capillaries in the brain. The parasitized RBCs occlude capillaries in the brain. This causes cerebral malaria. You also see kidneys and lungs, and the same thing with kidneys and lungs. Parasitized RBCs occlude capillaries in the brain and the kidneys and lungs. In Plasmodium malaria, there's a 72-hour cycle. Transmission is by Anopheles mosquito. Diagnosis blood smear is by blood smear. The trophocyte ring forms within RBCs, which is A. Right is it? Right here. So blood smear, trophocyte rings form within the RBC. So this entire thing is a RBC, and this right here, that's the malaria. That's the baby form of malaria that likes to infect RBCs. Schizont containing merocytes, red granules. Okay, that's B. Okay, so schizont containing merocytes. So this entire thing is a RBC, and the red granules seen in it, red granules seen in P. vivax and ovale. So this entire thing is a RBC. The red granules seen inside of that is from Plasmodium vivax and ovale. Um, um, red granules seen on PVAX and Vival, and this thing inside of this right here, it's a schizont containing merocytes. Schizont containing merocytes, which is just another stage in malaria. We're gonna get into that. Okay, so red granules throughout the RBC cytoplasm, seen with P. vivax and ovale. Okay, next. Treatment is by chloroquine for sensitive species. If they are resistant to chloroquine, you give mefloquine or atovaquone, proguanil. If life-threatening malaria, use intravenous quinidine or artesunate. Okay, and for P. vivax and ovale, add primaquine for hypnosite. Okay, so what we have to know is P. vivax and ovale both produce dormant hypnocytes and hypnocytes hide out in the liver. Yeah, both produce dormant hypnocytes. P. vivax and ovale both produce dormant hypnocytes. P. vivax and ovale both produce dormant hypnocytes, and hypnocytes hide out in the liver. Both produce dormant hypnocytes, and hypnocytes hide out in liver. Okay. Okay. So P. vivax and ovale, basically, you get fever on the first day, and then it skips 48 hours, which is 2 days, and then on the third day you get fever again. So the fevers are 48 hours apart. This is a symptom of P. vivax and ovale. The dormant form is hypnocyte, and that's in the liver. Okay, next is P. falciform. This one is severe irregular fever patterns. Causes more severe infections, so use artemisins. So this one is irregular, and it's a very scary one. No, there's no time frame of when the fever will strike. Severe fever, the RBCs with the parasite inside of them, the RBCs with the parasite P. falciparum inside of them occlude the capillaries in the brain, kidneys, and lungs. Occlude the capillaries in the brain, kidneys, and lungs. And then this is what gives you cerebral malaria. Okay, now the last one we have to know about is Plasmodium malaria, 72-hour cycle, and here the fever occurs on day 1, and then fever occurs again on day 4. So pre-malaria 72-hour cycle. Okay, P. vivax and oval is a 48-hour cycle. P. falciparum, there is no cycle. P. malaria, it is a 72-hour cycle. So this one shows up 3 days later. Okay, so you have fever on day 1 and 3 days later, which is day 4, 2, 3, 4. Remember, you never count the first day. 2, 3, 4. It shows up again, the fever. Okay, now something else you gotta know. Sickle cell disease is protective against Plasmodium falciparum. So sickle cell disease is protective against P. falciparum. Why is that? Remember we said the P. falciparum likes to go and occlude the RBCs with the parasite inside of them, likes to go and block off capillaries in the brain, kidney, lungs. I don't know why, but in sickle cell disease, remember the cells are sickled. So I just think of it like this: the RBCs can't get into the sickled cells, so the parasite can't get into the sickled RBCs. Therefore, it cannot infect them, and they can't go and occlude the brain, kidneys, and lungs. So just remember that. Okay, sickle cell disease is protective against Plasmodium falciparum. So a lot of people in Africa. I want to say, let's see how much percentage percentage of people in Africa with sickle cell. Well, Nigeria, it's 95% of kids are born with sickle cell. In Africa, this much percentage carries an allele, a gene for sickle cell. So Nigeria seems to have the highest spurts with the sickle cell. So think of Nigeria. People in Nigeria don't get Plasmodium. Majority of people in Nigeria do not get Plasmodium falciparum because it is having sickle cell disease is protective against Plasmodium falciparum. Okay. All right. Next. All right. And then artemisins are given for severe infections in Plasmodium falciparum, like in Plasmodium falciparum. Okay, now here diagnosis is by blood smear. You see tropocyte ring formed within the RBCs in figure A, which we just talked about right here, and schizont containing myristocytes, red granules throughout the RBC cytoplasm, seen with P. vivax and oval. Okay. The treatment: chloroquine for sensitive species. If resistant, give methylquine or atovaquone proguanil. Okay, so atovaquone proguanil for travelers to chloroquine resistant areas. So travelers are going to areas that are chloroquine resistant, which means that it is the tougher ones. It is a tougher form of malaria. Give them atovaquone proguanil. Okay. Now, in life-threatening conditions and malaria, give IV artesunate. So that's artemisinin. That's given for only severe malaria. So give IV artesunate and quinidine for severe malarial infection. For P. vivax and oval, add primaquine for hypnosite. So for P. vivax and ovale, add primaquine. For hypnozoite, for P. vivax, ovale, and primaquine. For hypnozoite test for G6PD. So mefloquine for travelers to chloroquine resistant areas. So you want to give, if somebody's traveling to chloroquine resistant areas, you want to give atovaquone or atovaquone, proguanil, and mefloquine. If somebody is traveling to chloroquine resistant areas. Okay. All right. So Vivax, ovale, add primaquine. P. vivax, ovale, add primaquine. Okay. So malaria and pregnancy. So let's see. P. vivax, give chloroquine until there really no primaquine. Okay. So basically, they're saying P. vivax and ovale give chloroquine and also add primaquine because you need to kill the hypnocytes. Okay. All right. So this is Plasmodium ovale. Okay, so these are the different types of Plasmodium. What they like to ask about is trophocytes. Trophocytes ring form within the RBCs. Okay, so this is the life cycle. Trophocyte is the baby cycle. So right here. So trophocytes seen in Vivax and Oval, that's the ring form, okay? So make a note of that. Trophocyte ring form within the RBCs, seen in Vivax, P, Vivax, and Oval. What is the treatment for this? The treatment is, it is chloroquine, and you can add primaquine to kill the hypnocytes. Okay. Treatment for P. Vivax. Treatment for P. Vivax and Oval is chloroquine. Chloroquine is chloroquine and primaquine. Primaquine. Okay. Okay. So treatment for P. Vivax and Oval is chloroquine and primaquine. And this is the stage you also see trophocyte ring form within the RBCs, okay? P-Vivax and P-Oval. And the schizont containing merocytes, that's also like a later stage of P-Vivax and Oval. It comes and infects the RBCs, yeah. Okay, so we're gonna get into the just the way it happens. The first way how malaria enters the body. Okay, how malaria enters the body. The Anopheles mosquito carries sporocytes in the saliva. Number 2, sporocytes travel to the liver. Number 3, sporocytes mature to trophocytes in the liver. Then schizont divides into merocytes. Number 4, the liver ruptures and releases the merocytes. Number 5, merocytes go on to infect the RBC. Number 6, life cycle continues inside the RBC. So, what is the life cycle? It goes from trophocyte to schizont to merocytes to infecting the RBC, and then more RBCs infected. So, the Anopheles mosquito carries sporocytes in its saliva and bites the human. Number 2, sporocytes from the saliva of the mosquito travel to the liver, and the sporocytes mature to trophocytes in the liver. So trophocytes are the baby parasitic form, but they mature in the liver. Sporocytes mature to trophocytes in the liver. Then schizont divides. That's the next stage. Is the schizont divides into merocytes. Then the liver ruptures and releases the merocytes. Releases the merocytes. And number 5, the merocytes go on to infect the RBCs. Life cycle continues inside the RBCs. So life cycle is it goes from starts from sporocytes, then trophocyte. So life cycle inside the RBC. I'm talking about only inside the RBC. It starts with trophocyte. Then it goes to schizont, then merocytes, then infects the RBC, then more RBCs are infected. So the first one is a trophocyte, then it ends with merocyte. Okay, life cycle of malaria inside the RBC. Now, next, Babesia. Babesia is this. You see fever and hemolytic anemia predominantly in the northeastern U.S. There's asplenia. Asplenia increases risk of severe disease. So, you see fever and hemolytic anemia. It's seen in the northeastern U.S. Lack of a spleen increases your risk of babesia. This babesia is carried by the Ixod's tick, which is also what carries Borrelia, Burgdorferi, and Anaplasma species. Diagnosis, diagnosis. Why did I say that word? Diagnosis is by diagnosis, ring form. Okay, diagnosis is by blood smear. You see a ring. Um, you see a ring in the RBC. See right here in figure C. There's a ring right here, ring in the RBC. Also, this is the main thing you see. This is the Maltese cross. See that? Maltese cross right here. That's only seen in Babesia. You can also do PCR to diagnose Babesia. Atovaquone and azithromycin is the treatment for Babesia. Now, I have to tell you, higher risk of babesia in sickle cell patients because sickle cell patients have no spleen, and having no spleen increases risk of severe babesiosis. So if somebody has sickle cell disease, they're at increased risk for babesia. So having sickle cell disease is a risk factor for getting babesia. Alright, so right here, Maltese cross in RBC. What is a Maltese cross? It's a bunch of trophocytes of Babesia gathered together, right? It's a bunch of baby Babesia gathered together and they make a cross, okay? It's called Maltese cross. It infects RBCs. What you give a treatment is atovaquone and azithromycin. Next. Alright. Okay. So we're gonna continue parasites. Okay. 2-minute break. Okay, so we're gonna continue. It's a longer break. Yeah, I know, but we'll need to be another break. Okay. So we're gonna be continuing with Chagas disease. Chagas disease is caused by Thalassemia cruzi. This is dilated cardiomyopathy with apical atrophy, megacolon, megaesophagus, predominantly in South America, unilateral periorbital swelling, which is the Romana sign. It's a characteristic of acute stage. Transmission is by the triatomine insect, which is a kissing bug. It bites and defecates around the mouth or the eyes. There's fecal transmission into the bite site of mucosa. Diagnosis by tryptomastiga in the blood smear. Treatment is by benzimidazole or nifurtimox. Okay, so what do? What do you see? Chagas disease. What is Chagas disease? Dilated cardiomyopathy with apical atrophy. Okay. Dilated megacolon. Dilated cardiomyopathy. Cardiomyopathy. Chagas. Okay. So okay. Cardiomyopathy. The ventricles. So the lining, interventricular septum. Oh my goodness, interventricular septum. The lining underneath the left ventricle, right ventricle, they're all thinned out in cardiomyopathy. Dilated cardiomyopathy is when the chambers dilated. So the chambers, I believe, are enlarged. Chambers are enlarged, and the lining between the ventricles and the atrium, they're all thinned out. Look. Heart with dilated cardiomyopathy. Heart chambers enlarged. Yeah, the chambers enlarged. See this? This is the normal heart. The chambers enlarged, and the it's all thinned out. The lining around the ventricles, they're all thinned out in dilated cardiomyopathy. Okay, this is what you see in Chagas disease. Megacolon is just a huge colon, so large intestine. The large intestine is huge. Megaesophagus, the esophagus is also huge. Chagas disease affects people in South America. You have periorbital swelling, which is unilateral. So unilateral periorbital swelling, Romana sign. Romana. Okay. So you see swelling on one side of the face. One side of the face. This is Romana sign, okay? Okay. Acute stage, that is the acute stage of Chagas disease. This one, dilated cardiomyopathy, megacolon, megaesophagus, that's later stages, okay? Transmission is by triatomine insect, which is the kissing bug. Yeah, it's a kissing bug. It's also known as a reduvidant. Yeah, it's transmitted by the reduvidid bug. Reduvid bug. Reduvid bug. Yeah, this bug. Reduvid bug. Okay. So also known as the kissing bug. Okay. Also known as the kissing bug or triatomine insect or reduvid bug. It bites your skin and then poops around the mouth or eyes, and fecal transmission into the bite site or mucosa. Alright, so the kissing bug bites around the patient's mouth and deposits poop, which can get inflamed when the patient scratches the area. Okay, so basically just think of like the patient spreads the poop around on their face because it's itchy, so they bite it. I mean, so they after the bite. Okay, so the patient scratches the area after the bug bites them because it's itchy and spreads the poop around, and then the area becomes inflamed. Diagnosis is by tryptomastigot in the blood smear, which is A right here, figure A, tryptomastigot. Okay. Diagnosis by blood smear. Tryptanosomes may be seen within the cardiac myocyte or heart biopsy. A treatment. Benzimidazole or nifurtimox. Okay. So on blood smear you see tryptomastigots, or you can do a biopsy and you can see trypanosomes within the cardiac myocytes or on heart biopsy. Yeah. Next, leishmanias. Okay, leishmania. There's two types. Okay, so the first type we're going to talk about is Leishmania donovani, and then the second type is Leishmania brasilinus. The first visceral leishmanias, also known as Calazar. You see spiking fevers, hepatosplenomegaly, pancytopenia. This visceral leishmanias is caused by Leishmania donovani, and I'm going to show you a picture right now. It is hard to look at, just letting you know. But the reason I'm showing you a picture is because nothing will stick like a picture. Visceral leishmanias. Okay. See this visceral leishmanias. Okay, so you see spiking fevers, hepatosplenomegaly, pancytopenia. Let's see, causes. So these are all symptoms of it. Visceral, this is visceral leishmanias, and this one is cutaneous leishmanias, okay? Calzar, let me see, Calzar, Calzar. So we have extreme muscle wasting, cachexia right here, swollen lymph glands, thrombocytopenia. Oh, that's very sad. Yes. If left untreated, this manifestation of leishmanias is fatal more than 90% of cases. Yeah. So this one is a really bad one. Calazar, this is worse. Leishmania donovani is worse than Leishmania brasiliensis, which causes cutaneous leishmanias. And this is skin ulcers, okay? Skin ulcers, which you can see right here. Let's see. Cutaneous leishmanias. So these are the skin ulcers. This is cutaneous leishmanias. This is here. Right here, we're gonna look at figure B, which is that cutaneous leishmanias right here, and then this leishmania species is transmitted by the sandfly. Okay. You see macrophages containing a mastocyte. Okay. C, right here. This entire thing is a macrophage, and you see a mastocyte inside the macrophage, and this is a sign of leishmania. Okay. Your treatment is with amphotericin B and sodium stibogluconate. So visceral leishmanias, visceral leishmaniasis, you treat with amphotericin B. Remember, amphotericin B is what you give for the worst of the worst cases. So visceral leishmania, Calazar, black fever, you give amphotericin B, and then cutaneous leishmanias you treat with stibogluconate. Okay, stibogluconate. That's what it is. Leishmania brasiliensis, which causes cutaneous leishmanias, and this parasite lives in the human vertebrae. Okay, so just remember that, and it affects the macrophages. If I asked you what disease is caused by the tsetse fly, what are you gonna say? It's Trypanosoma brucei, tsetse fly, painful bite. This one causes African sleeping sickness. Don't get it mixed up, okay? This one is enlarged African sleeping sickness. African sleeping sickness is caused by Trypanosoma brucei. It is enlarged lymph nodes, recurring fever due to antigenic variation, somnolence, and coma. It is carried by the tsetse fly. Let's see. Okay, and leishmania is is uh is transmitted by sandfly. Okay. Now, Trichomonas vaginalis causes vaginitis, which is a foul-smelling greenish discharge, itching and burning. Do not confuse with Gardnerella vaginalis. Okay, Trichomonas vaginalis causes vaginitis. It's a foul-smelling greenish discharge. You see, you have itching and burning. Do not confuse with Gardnerella vaginalis, which is a gram-variable bacterium associated with bacterial vaginosis. So, Gardnerella vaginalis is a bacteria. Trichomonas vaginalis, it's a parasite. Okay. All right. And Trichomonas vaginalis, you see green discharge. Gardnerella vaginalis, we're just going to quickly go into that. Gardnerella. Okay. Come on. Go. Gardnerella. Okay. So Gardnerella is a pleomorphic gram-variable rod involved in bacterial vaginosis, presents as a gray vaginal discharge with a fishy smell. Trichomonas vaginalis and Gardnerella vaginalis both have a fishy smell, but Gardnerella vaginalis is a gray discharge, and Trichomonas vaginalis is a green discharge. Okay, the Gardnerella vaginalis is not painful, whereas Trichomonas vaginalis is painful. With green discharge. Okay, that is Trichomonas vaginalis. Okay. Okay. So Gardnerella vaginalis is where you see clue cells. Remember the picture for clue cells. It is important. Clue cells are vaginal epithelial cells covered with Gardnerella. Okay. So remember we said the amine whiff test. If you mix the gray discharge from Gardnerella vaginalis with 10% potassium hydroxide, the fishy smell will get worse. Okay, the treatment is metronidazole or clindamycin. Okay, so we're just quickly compare and contrast both of them, so it's easier. Don't get mixed up. People get mixed up all the time. Okay. Trichomonas vaginalis, it's bisexual contact, it's spread by sexual contact. Trichomonas vaginalis cannot exist outside the human because it cannot form cysts, so it can't form baby worms. Hey, that's how I think of cysts, baby worms. Okay, let's see. Trophocytes are motile on wet mound, so they move on wet mound. They punctuate cervical hemorrhages. You see punctuate cervical hemorrhages on the cervix. So wet mound is to observe motile organisms on vaginal wall of patient. That's what wet mounds are for. And here, when you do the wet mound, you see trophocytes, and you see you see them moving around. Okay, and you see strawberry cervix here. which are red bumps on the cervix, like a strawberry. So you're not gonna forget this picture. Let me show you. All right, strawberry cervix. This is what it looks like. Strawberry cervix, like dots, on the cervix. Um, right here, like dots on the cervix, like a strawberry. That's why they call it strawberry cervix. Okay. Don't forget, okay? That's like a buzzword. Strawberry cervix. Alright, next. Pro tip. If you're ever confused on if you're ever confused with this, I always for the longest time, maybe not for a micro, but for immuno, if I were Google things, I would not understand what they were talking about. So I always go to images. Always go to images, scroll down, scroll around. They're always correct. And people have done numerous publications and scientific research. It's backed by scientific research and PowerPoints and presentations of medical students, residents. So you'll never fail. Make sure you go to images and look through the images, compare and contrast. Plus, you'll never forget it. All right, let's go. All right, and then treatment is by metronidazole for patient and partner. Prophylaxis. Check for STI, sexually transmitted infection. So yeah, metronidazole, you gotta treat the partner too. Otherwise, they'll just keep reinfecting each other. The partners keep reinfecting each other. So you had to give metronidazole to him also. Him, her. Alright. So D. Okay, so D is trophocytes moving on wet mount. Trophocytes of Trichomonas vaginalis moving on the wet mount. I'm gonna make a note of that. The pictures are very important to be familiar with. Okay. Yeah, trophocytes, on wet mount, trophocytes on wet mount, seen in Trichomonas vaginalis. Okay. Next. Nematodes, route of infection. Okay, so these are the worms, how they get into your body. Okay, ingested, the ones that you eat. The worms that you get by eating is Enterobius, Ascaris, Toxocara, Trigonella, Trichuris, and then the one you get from skin strongyloids, and then what is it? Ankylositoma. I can't say these words. Okay, let's say strongyloids. So that strongyloids. Okay, so strongyloids, the larvae in the soil penetrate the skin. Okay, I got it. So basically, you're walking around barefoot, and then the worms from the soil get into your blood by going through your feet. That's what that means. The ones that enter through the skin. So the ones that enter through the skin. Parasites that enter. Parasites that enter. that enter parasites that enter and enter skin and that enter skin. Sorry, that enter body through skin. Okay, so cutaneous, it just means that parasites enter the body through skin, and there are strongyloids and ankylostoma and necator. The parasites that enter by biting is loa loa and onchorecca volvulus, which carry a Bancrofty. Alright, I'm gonna get into this. Okay. Actually, should I cut this? Okay, so I think I'm going to cut this video here and then continue. I think we have three pages of parasitology left, so I'm going to continue that in a separate video. See you then.